Yeah, my name is John Allan. I'm a psychiatrist. As you said, I'm just about to become the President of the Royal Australian New Zealand College of Psychiatrists, which is a binational organisation with members in Australia and New Zealand and interests in Southeast Asia and the Pacific and the world. My day job is that I'm actually the Director of Mental Health, Alcohol and Other Drugs in Queensland.
So as you come into the role, you've been President-elect obviously for a year, but what would you say is your vision for the college under your helm?
Well, look, the college's vision is really to help improve the mental health of all people, particularly in our two countries, but also around the region as well. So we want to contribute to mental health in all sorts of ways, and we do that mainly as a training and standards organisation. So we're a membership organisation of all the psychiatrists in Australia and most of the psychiatrists in New Zealand. And our aim is to make sure that the education, ongoing education, training and support for psychiatrists is good. We run strong training programs to help people become psychiatrists. We've got about 1,000 people in training in psychiatry across both countries. We need to do that, so that's one of our aims. Another aim is to make sure that we have really good information and support for the public, so we have a very strong community focus. We have a Your Health and Mind website, which contains lots of information for people about mental illness and how to get help and what to do and what psychiatrists do. So that's one of our factors, and we really work with the community in all of our work. We have people from the community on our various committees and so on to help us. That's one aim. And the third one really is in the area of advocacy, where we actually look to funding bodies, other groups, other colleges to make sure that mental health is a top priority. So we work hard to get good standards, good care, equity of care, availability, and to obviously try and increase the size of the pie.
We've heard from Kim Jenkins, your predecessor, that psychiatrists should step up their advocacy in Australia, and we've heard calls for that here at the Congress on climate action, on refugees, on food industry dominance, range of issues. And I know that you've been personally involved in physical health for mental health and emergency department acute care. Yeah. What do you agree that you need to step up in advocacy, and where would you look to do that?
Well, hopefully we're stepping out already, but we can step up a bit more as well. The college is really interested in advocacy and anything that affects a person's mental health. So that's quite a broad statement. So we don't advocate for everything. As I'm trying to make the point is that we look at things that we have some professional expertise and some capacity through research or through work to contribute to. So for me, the next steps in our advocacy, we obviously advocate for a number of things with government. The mental health burden in this country and throughout the world is quite high, and commensurate with spending, there's much lower spend on mental health in terms of health dollars and welfare dollars than relates to the size of the burden. So there's about a 15% burden of health, but we only get about 8% of the funding. So we want to see that proportion come up, and that's a real major aim, and that relates to everything that we do. You've mentioned a number of things about food, climate, other things that affect our mental health, and we obviously advocate in those spaces as well. In particular, we've been really strong about the physical health of people who suffer from serious mental illness. It's an absolute tragedy in our community that people who have a serious mental illness die on average 25 years earlier than other people, and that's due to a combination of their illness, the way they're treated through the system, lifestyle factors. We want to work with people to change that, so that's a big part of the advocacy. And the other thing that we'll be launching very soon is an advocacy campaign about alcohol and mental health. One of the things that people realise that there are issues to do with alcohol, but often people are quite unaware of the effects on your mental health that alcohol has. Not just the direct effects on depression and anxiety, more than just a hangover, but also those indirect effects on society through domestic violence, child abuse and so on, that have a high correlation with alcohol abuse. And it's one of those drugs that tends to get ignored in our society. People concentrate on the evils of illicit drugs, but they don't actually look at the most common problem, which is alcohol and the effect it has on people's mental health. So we advocate on all of those issues, and we have a number of other sort of lower range and out there according to the need issues that we look at.
What about in terms of advocacy around the profession itself? And you raise the Equally Well campaign on physical health of people with mental health issues. A lot of the consumers at that symposium that you were at brought up the impact of actual treatment and medication on them. So the impact of psychiatrists on them.
Absolutely.
Where do you what are your priorities there?
Well, look, all advocacy has three targets. One's the government, you want to get something out of them. The other one's to educate the public, and the other one, in the middle, is what do our members know and what do our members do, right? So we want to make sure that our members are the best equipped they can be to deal with those issues. In relation to the one about medication, there's been a lot of evidence in recent times about using the lowest doses possible of medication, whether or not it's possible to stop medication when it's able to do so. There's been really interesting evidence presented actually at the Equally Well about that, about which people are suitable for changes and so on. So we want to make sure that our members are well educated about that. I think that in the past there was an issue of, well, that medication works a bit, so we'll give a lot more and that might work a bit better. Don't worry about the side effects and the consequences. What we actually look now is about how selective we can be, how people understand the side effects, how people can use early interventions and challenge that. So for example, a really interesting thing that was presented at that Equally Well symposium was about people with early psychosis, how appropriate training in exercise, diet, looking after yourself, the right attention to medication can actually prevent that weight gain that people expect to get when they go on an antipsychotic medication. So many of those, in that work from the Bondi Clinic, many people didn't get the expected weight gain because they actually made the appropriate changes in their lifestyle that allowed them to compensate for that change with the medication. So there are lots of better ways that we could do that stuff, and that's part of what we need to get out and change.
Okay, so that's what the Congress here is a fair bit about, is about education and opening up people to think outside their field. You were the convener of the Congress as well. What's your big takeaway from it, and what have been your highlights?
Look, the highlights for me have been many. One is that we've had so many people, that's a great thing, but also the engagement with people. We've had a number of fantastic and keynote speakers from a wide variety. So we really addressed things from the the mental health of Indigenous people in Cape York, a really detailed look at psychosis and the evolution of psychosis in Cape York, and in particular how that related to social conditions. For example, the loosening of conditions in the 80s, and how there's been some change with alcohol management plans to try and get some better control of the development of psychosis. So it shows how social conditions can change things. We've had some really great work about treatment of PTSD and how a program that's tailored to that person and takes account of their needs can actually make a real difference in PTSD, which is a terrible thing that affects our community. We've talked about nutrition and the value of appropriate eating and the way it affects mental health. I thought that was really an eye-opener about how much depression and anxiety can be prevented by simply paying attention to your diet. And we've known for a long time about exercise, now we know about diet, so it's been fantastic. We've talked about the legal and moral implications of data and data recording and what happens to your health record and what happens to all those studies. And really food for thought. We've talked about today we've talked about the health of doctors, how they're not really that different from anybody else, but how it's really important that we all look after ourselves and look after our health and stress. And we've talked about some really fantastic new horizons in genetics and how we'll be able to predict people with illness and how we can look towards better methods of preventing those illnesses. So that, and then the satellite symposiums, of which there's been many, we've had this huge variety, all of a challenge to people's education. How can I find out more? What can I change in my practice? What do I want to know about? And and just I might not work in that, but that's jaw-dropping to know the advances that people are making.
And we know you work on congresses long before they happen, so life changes, issues change, etc. Are there things here missing that you wish were there? And there's been some discussion on Twitter about having a higher role for consumers here, that you didn't look at treatments like seclusion and restraint, right, things like that.
Sure.
Where do you agree that? And on the social determinants,
yeah,
a bit more of a focus on that. Do you think that they're valid
They're
critiques?
all, well, I think that they are, you can't have everything.
Mm-hmm.
So just to pick one of those, there was some great work on seclusion and restraint actually in a session that I was at, and some rapid fire papers presented from some people in Western Sydney who had actually taken the seclusion and restraint rate from quite high in a unit in Western Sydney down to 0 over 2 years, just through a whole lot of interventions they'd made, and we only gave them 8 minutes to tell us all about that.
My humble apologies
so
for missing.
There was some, which I actually attended, and there was some other fantastic work on that. But you know, I've also been part of the TERP conference, which is the National Elimination of Restrictive Practice, which we hold every year or a year and a half or so, which talks specifically about those issues. So you can't fit everything in, but yes, we do that. We've had quite a significant involvement with consumers and carers, particularly Indigenous people in some of the sessions. We've had quite a representation with consumers and carers. So for example, the Advocacy campaign, we had a consumer participation in that. We're really interested in making sure we keep that level of consumer participation. We've given lots of bursaries to early career psychiatrists, consumers and carers, but I think we can always do more. And yeah, I think those are all things that we will pursue.
And what about things that you would like to see next time?
Well, we always look at what's topical, and we've got a grid of about 100 things, and we look at how can we get all of those things. So when we get our keynote speakers, that does about 6 to 10 of the things on the grid, and then we get some invited speakers, that does another 10 or 12 things on the grid, and then we look for the papers and try to see how we fit those in. So I think that there's more things that we could do. Like for example, I don't think we've done a lot about anxiety this time. I think that I was talking to one of the keynote speakers, was talking about digital data. We haven't got enough on digital mental health this time, even though we've actually got strong representation from our digital agencies here, and the chair of the Digital Health Board was here. So but we just didn't have enough of that, because that's what so all those things are open, and that's why we have a new person convene Congress. We have a handover, and we say, well, this is what we did right, this is what we did wrong. You've got any other ideas? How would we change that? I'd like to have made, we had some really fantastic work from Ernest on Indigenous things, but for example, we've got an Indigenous prize for people's work on, Ernest's been a previous winner. I'd like to see the winner of that prize get a keynote address. I'd like to see some of that work for some of those people who got prizes for some of their research, having more opportunities to present that in a bigger forum rather than being up that room up the back as I was talking about, because we've got to fit everything in. So it's always competing. You always got to make a choice about what you highlight and what you don't highlight. So hopefully we can listen to the feedback.
And one of the things that you did highlight at the beginning, of course, was the launch of the foundation.
Yeah.
Can you tell us about that?
Sure. So the foundation, the college has always had a bit of a foundation where we take grants and donations and hand those out to try and encourage research and so on. But what we've realised is that we have a responsibility to the community to actually make things better. And there are three kind of general areas we're going to do that. One is that we want to really encourage research in young fellows and registrars and early career psychiatrists, because sometimes it's really hard for them to get a grant, and if we can give them a seeding grant to actually get that idea, get that proposal worked up, that will help them to be more research ready to get to those larger grant things. But we're also hoping those will be focused towards the community, so that's one. Secondly, we're hoping that some of our grants will go towards psychiatrists who pair with community groups and pair with consumers and carers in looking at issues that are of interest, mutual interest, right? So often they're hard to get seeding grants for too, so we want to look at that. And thirdly, we will look at areas where there's quite a disadvantage. So obviously for Indigenous communities in Australia and New Zealand, but also in the Pacific, we've been working for quite some time with a number of psychiatry specialists and organisations in the Pacific. So we want to be able to make sure we can work with their education, training, and what opportunities we have to develop the profession in those areas. And then there are other countries in Southeast Asia that we also volunteer and work in. So we're hoping that the foundation can help us with more of that volunteering, development, training, mentoring, connecting throughout those areas.
Fantastic. Thank you very much, John.
Thank you.